Everyone. Americans for Safe Access is excited to bring this press briefing to everyone. We wanted to make sure that as we are moving into the next phase of the scheduling process, that we're hearing from a variety of voices that are impacted by scheduling. There's been, obviously a lot of news around the topic. And even though the decision or the proposed decision to create to move cannabis into a Schedule 3 is based on its accepted medical use, we're not seeing a lot of media coverage about that. And so today is the last day for public comment on the proposed rule. And we want to make sure that as reporters are continuing to cover this during the sort of waiting period for a response from the DEA, to let them know that there's a lot of stories behind both what's led up to rescheduling as well as who's going to be impacted by that. And so, as you guys all know, that this current rescheduling process was initiated in October 2022 by the Biden administration through a statement from the White House. This rescheduling petition or process is very different from the other 5 processes we've seen, which were all initiated by petitions. And so for patient advocates, this was a pretty amazing day when we found out that the top health agencies in the country agree and validate our experience that cannabis has currently accepted medical use and treatment in the United States. This is, again, we'll talk a little bit later about what it does and doesn't mean, but for patients who have been trying to have a conversation with their federal representatives about providing access to medical cannabis, this has always hung over us, right? That we had to sort of get past this conversation before we could talk about national access. And so right now, sorry, my presentation likes to jump. We are finishing up public comments today. And so what will happen is this is now in the hands of the DEA. They asked a lot of questions that were present in the proposed ruling. And so they're going to be sorting through public comment and they can determine if they would like to have an administrative hearing to finish answering those questions. They feel like they need more information to be able to make a determination. And so that there's almost 39,000 comments so far, and we have until midnight this evening to finish those public comments. So the DEA actually has to respond to all of those comments. So that's a little bit of work there. And there's not a time limit on when they need to respond. I know a lot of people are hoping that this will get decided before the election. There were a lot of stakeholders that asked for an administrative hearing. And in the DEA's comments, it seemed like they were sort of gearing up for an administrative hearing. And then once the DEA makes the final ruling, then there's a period of time for legal challenges. And, I'll say at any time, Congress could step in and reschedule cannabis. They have the authority to do that at any time. They just haven't. And so because this was done through executive order, there are, a few other factors that the Office of Management and Budget will be looking at before the final ruling. And then, of course, depending on the timing, a new POTUS could actually modify or revoke this process. And so, the process of rescheduling includes OMB review, congressional review, judicial review, and then, of course, the potential of the administrative hearing. And so even though it feels like we're coming to the sort of end of a lot of the steps, really a lot will be decided in these next stages. And a lot of people are weighing in. As I mentioned, we've seen a lot from the sort of anti-marijuana lobby, weighing in on this issue. And I think a lot of that is their response to reporting around the business side of things. We haven't heard a lot from patients and the healthcare sector, who are all sort of, have all weighed in along the way and are really hoping to see some clarity on this for patients. As I mentioned, this is open until this evening at midnight, and quite a few people have weighed in. And as far as ACE's comments, a majority of them are that we support this concept, and I'll talk a little bit more about some of the details that we see that the DEA is going to be looking at, as well as some of the impact. So I'm going to stop sharing here and really hand over the floor to many of our panelists who are bringing so much to this conversation. And so, Ellen, I would like to start with you. I know, Ellen, we've worked together for years in trying to create a pathway for rescheduling. And so I'm excited for you to share your experiences as a medical cannabis patient and what this process has meant to you.
Absolutely. Thank you for this opportunity. Unfortunately, I'm now 74 years old, but the good news here is that I would not be here at this age had it not been for the honor of using cannabis. I have a condition called Ehlers-Danlos. Originally, they thought it was 1 out of 5,000 that got this. It's actually now NIH said 1 out of 600 people walking around. The problem with this condition is we live with continued pain, progressive pain, and it will never go away. Yet we also are drug reactive. I had DNA drug sensitivity testing done with the 7 surgeries I've had. It's a problem in the hospital because I don't metabolize normally. So the testing came back, and the one thing I am able to metabolize for pain relief is cannabis. I started in 2006 at a time when it was nothing but stigma against it. And even my own children thinking, what are you doing? You're going to be in danger. But fortunately, living in the state of Rhode Island, it became legal here. But I could see, losing my career of teaching, that this was a battle I needed to take on and help advocate other people to feel, number one, not scared of it, because now, as it's been proven through my use of it, it is medically acceptable. No one dies from the use of it, and that we actually are benefiting in a safe way with pain relief. And people are, including, every aspect of society, have been afraid of this because we've been taught and brought up to believe that cannabis is a dangerous, horrible drug because it's been sitting in Schedule 1. So my life since then, and finally getting diagnosed with what I was born with at the age of 54, which is inexcusable, has been trying to help change society's attitude about the use of cannabis, and obviously would love to see equal access across the country for this. It is incredibly enlightening to know that we now can have society agree that this is accepted for medical use, but now we need to make it a possibility that nationwide is equal for all people. I have spent my life going to these surgeries, going into a hospital and telling them what I can only use for medication, to being told, sorry, you cannot use this in the hospital. We're really sorry, and have to lay there and suffer. And that's not acceptable. Yet I can walk home to my home and legally use it. So this doesn't make sense. I then have to travel for many of my surgeries. And again, what do I do when I want to get onto an airplane? Once again, here I go again, because from state to state and traveling, there's always those issues too. And yet here I work with US Pain Foundation. My husband and I are co-directors for cannabis advocacy for this. We have over 51 million people in this country dealing with pain and dealing with these same issues that come along with this. Is how do I know it's safe for me to use it at this location? Can it only be at my house? And how heartbreaking it is for me knowing how somebody with my condition in particular doesn't have many options, and yet they might live in a state where they haven't had any access at all, and they do nothing and suffer. I even lost a nephew already to my condition because he did not have access normally in his state of Texas, and it was heartbreaking. he turned to alcohol and lost his life for it. So we need to see that this becomes something that is equally access to all people in this country, and that these issues that are being brought up can be resolved by turning to Schedule 6. All these other issues are going to make a huge difference, and we will see everybody having the same opportunity to consider using cannabis as a pain relief or for whatever medical issue that they have. Thank you.
Thank you, Ellen. Ellen, I just want to also just thank you for being such an amazing advocate. You definitely inspire me, and I know everyone that comes in contact with you is inspired by your work. So thank you for your tireless advocacy. It's much appreciated. And now, I think behind every patient story, there is a physician or a medical professional that is, either fostering their ability to participate in the state program or guiding them along the pathway. And I'd like to turn over to Dr. Lee Vinegar, who is not only a physician treating patients in the state of Maryland, but she's also an advisor to Americans for Safe Access. So thank you for joining us today, Dr. Vinegar.
Thank you for having me, Steph. And I appreciate and understand everything Ellen said, because as a physician who integrates medical cannabis into my patient's treatment, this change, I welcome the step forward, but I feel like the journey's far from over. Rescheduling it is progress, but it doesn't solve critical issues about accessibility that Ellen talked about, affordability, or even safety for my patients. It's good that the FDA and Department of Health and Human Services and Justice agree that there is accepted medical value. So by definition, then it should not be a Schedule 1, but my patients are accessing cannabis outside the federal laws. And these issues that Ellen brought up, that they bring up all the time, rescheduling it to Schedule 3 isn't going to make a difference. It's not going to require a prescription by doctors. They'll still have to get it outside the federal laws. It won't be affordable. It won't, insurance won't cover it. Interstate travel will still remain a problem. And patients in states, like she pointed out, Texas, they lack access. And then there's the issue of consistency, safety, and quality. There needs to be a national standard to protect patients, to make sure that there's quality and consistency. When you're using medical cannabis for serious medical conditions, you need a consistent medicine. And it's still kind of this piecemeal work that they're trying to patch together throughout the states. The other issue is, I've had patients that were taking it for hospice at the end of their life. And truthfully, if they had to go inpatient, they were denied this. So they were put on opioids, which actually took away critical time with their loved ones at the end of their life, because most of the time they were just sleeping and zombies, just to maintain pain-free existence at the end of their life. And there needs to be a national program. I totally agree with Americans for Safe Access and their proposal of a new office, Medical Cannabis and Cannabinoid Control Act that's being proposed. So there is something that is national and that is consistent, that creates a safe medicine for all my patients, no matter where they are, if they're inpatient or something like that. I mean, I, as a physician, have practiced through the opioid crisis. And as a physician, even though unwittingly, we were part of it. You know, we were told a short term, there's no addiction potential, which we now know isn't true. And this, I mean, regardless, is a much safer alternative in my medical opinion. And it's something needs to be done. And it's just seems so ridiculous to me that something like Marinol, which is THC, is a Schedule 3. So I understand that the federal agencies are going to bring it to Schedule 3, but it's not going to change anything for my patients. They need more, they deserve more. They need to not be discriminated in their housing. They need to get affordable cannabis. They need to get it anywhere, regardless of what where they live, and they need to be able to travel. So I strongly urge Congress to scrap this piecemeal approach and create a comprehensive program that was set out by Americans for Safe Access. And I apologize, my camera's not working on my computer.
Thank you, Lee. I really appreciate your comments. I think there's a lot of doctors that don't even know that cannabis is a tool in their toolbox for treating patients. So I really appreciate your efforts to educate yourself and others on the topic, and participating in the regulatory process in Maryland to ensure that patients are safe. For folks that are listening in, you can add questions in the comments. We're going to do Q&A at the end. So I want to again we're creating space to hear these various voices, and I want to thank the panelists again for joining us today. And now we're going to hear from Michelle Wright, who is also a very inspirational speaker, and someone who has come to medical cannabis in her life a little later, but has really not only brought that as a caregiver into her son's life, but also has become a tireless advocate as well. So Michelle, thank you so much for joining us.
Thank you, Steph. Hi, everyone. I'm Michelle Wright, and as Steph said, I am the parent of a 32-year-old son, Ian, who is profoundly affected by autism. My son's part of a minority of those with autism that you really don't see on TV. He is a 2 to 3-year-old in most developmental areas. Remember that, like try to think of you're a 3-year-old, the child or grandchild. Ian needs help with everything from dressing to bathrooming and needs round-the-clock supervision, and he will for his whole life. Similar to others in this population, he also struggles to communicate, which adds to his frustration and behaviors. My family has been so devoted to taking care of Ian, and we've tried conventional methods of treatment, including, among other things, nearly 20 different medications, often given 3 to 5 at a time by well-meaning doctors. By age 27, my baby, since it's my baby, my 3-year-old, had severe facial tics and Parkinson's tremors, like your grandma. He wore a helmet for hours a day to protect his head from injury as he slammed it into walls and floors and cement and glass. He had continuous episodes of psychosis and catatonia. He was so lost in his mind that he stopped eating and even using the bathroom regularly. He lost 40 pounds, and we were told to think about even more medication and psychiatric stays inpatient and maybe electroconvulsive therapy. All this for, remember, like a 3-year-old to me. We had tried so much, and then we did try medical cannabis, which had recently become legal in our state. As Dr. Vinegar said, doctors were never trained beyond the dangers of cannabis. So we were told absolutely that we were harming our son and experimenting on him. We felt very alone and scared, but the cannabis did start to work slowly. And after 2 years, Ian was then off all of his medications except for one. He gained back about 20 pounds over that time and was a healthy weight. And nearly 5 years later, he is a happier and fuller version of himself. He still is profoundly autistic. That won't change. and he still watches Barney the dinosaur every day. He still has tantrums, but now he smiles, which he didn't before. And he takes walks with me and holds my hand, which he couldn't do before. His tics and tremors are gone. He wears a helmet only occasionally. So medical cannabis has literally given my son, my baby, back to me. The doctors still don't understand it because it still isn't largely taught. And so we're on our own, really, to manage his medication. So I did go back to school and get a degree actually in a pharmacy school to learn the science around it, but I am not a medical professional. So it is still isolating. There is still a stigma and judgment from others. I remember when I heard on a call with Americans for Safe Access from STEP that our government now recognized that cannabis had accepted medical use, and the scheduling would be reviewed. I remember going on mute and like sloppy crying, like silly. Just crying. I'm not an emotional person, but I was crying. Rescheduling cannabis means it can now be researched, which is a big deal. That comes with education for and acceptance from our medical community. So patients aren't on their own, hopefully, sometime soon. But for our day-to-day lives, like the doc said, not much will change, right? Without comprehensive reform, even in a state where cannabis is legal, my son will struggle to access his medicine without me, because he doesn't take a drug that's available for prescription under the FDA. He takes capsules. He takes cannabis capsules that we make for him at home. So even with the rescheduling, he'll be stuck between these federal and state laws that do affect his ability to travel, to be treated in a hospital, to afford his medicine, and even to obtain housing and public services. None of that changes, even in a state where cannabis is legal. So I'm grateful for the work thus far, and especially for all the promise of the research. But I ask that our legislators, regulators, the medical community, the press, the public, everyone, not fall victim, to the rhetoric around the cannabis industry and cannabis use. Please consider the patients. Please, please consider my baby. Thank you.
Thank you so much, Michelle. Yeah, I appreciate that perspective so much. And it's, I think what is a challenge for a lot of patients right now in sort of seeing this rescheduling process is that once again, they don't see themselves in the conversation. And I think a lot of patients who are in states that have added adult use are finding, that there's this assumption that if cannabis is just legal, then that deals with all of the issues facing patients. And really the reality for a lot of those patients is that the discrimination has gotten worse, because there's not an exception or a difference, and also they're finding it harder to find the products that they need. And so I think Michelle, one of the points that you made is that you're responsible for bringing your son his medication, for making that medication. And I think that brings up another sort of area around a lot of the myths that we've been hearing about what rescheduling means. I know patients and patient advocates have been really hoping to be a part of the platform to correct a lot of this information. And so I'm very excited that Brian has joined us to give us some perspective as not only a pharmacist who can kind of plow through some of those myths, but also in the state of Connecticut, pharmacists have actually been a part of the program, and I think is a view into what a future national program could look like. So thank you so much for joining us, Brian.
Thank you for having me. I appreciate it. And Michelle and Ellen, thank you so much for your stories. This is the stuff that gives me goosebumps. This is the stuff that has me in this industry. And I can't express that enough. I'm a pharmacist. I worked in retail pharmacy for 16 years with Walgreens and saw just the absolute horror that pharmacy can do to people with the polypharmacy and all of the meds and everything else. And really just got very distraught and disgruntled with how medicine is working. And finding cannabis and the cannabis industry for me gave me a whole new outlook on medicine, on healthcare. And I got goosebumps every single day I walked into work. I was able to have conversations with patients about how to improve their quality of life, their outcomes, how to reduce their medications without all the pushback that you normally get from clinicians and everything else too. And it really got me to fall in love with medicine again and to help patients. And that's really what it's about. And I think the rescheduling of cannabis is step one. I think we need to deschedule. That's a whole nother conversation for a different day. But what this does is it allows at least clinicians to feel confident that they are prescribing something that is safe and effective, that, you know, even though they've been taught this for years, hopefully we can finally start getting some education in the classrooms to help them understand what it is we're doing and how we're doing it. I think it's really important to understand that you cannot patent a plant. So you will not see these medications just, you know, flowing into pharmacies and everything. The only FDA approved cannabis medication truly right now is Epidiolex, which took, I think it was 7-8 years at least in order for that to get approved. So you can imagine that any other cannabis medications that would be prescribed through a pharmacy are going to take at least that long, if not longer. But as some of the other panelists have said, this opens up the research to cannabis. This allows your pharmaceutical companies and any of the other big companies, especially here in the United States, to do the kind of intensive research that we really want to get us the information so we can all feel comfortable about drug interactions and you know what other type of effects it has and how actually cannabis works on all of these conditions. And I think the drug interactions is, you know, for me personally, one of the places that I really, you know, pay attention to. There are some interactions there, especially with medications for seizures, such as Onfi, Keppra are some of the big ones that are really, you know, common medications that you see there. Blood thinners have interactions with CBD as well. So it is really important that you let your pharmacist and your clinicians know that you are using cannabis. Whether or not they agree, that's up to them. That's their problem to deal with. But it is important to let them know, because not only are there potential interactions, but if you are having benefits, positive outcomes from using cannabis, we don't want the clinicians to believe that it's the medication change that they made or that you're improving because of that. And also having that conversation with them to be able to decrease dosing and decrease medications as well, so we do that properly and correctly. You don't want to just go cold turkey off of any medication. That can throw you into a complete tailspin. And the majority of the patients that we have that are using cannabis have been through the polypharmacy, have been through, you know, tens and tens of medications that have worked, haven't worked, and, you know, they've gotten really disgruntled with the regular healthcare system as well. But in order for them to do this properly and to make sure that they're getting the relief that they need, and making sure that the clinicians don't believe it's something different that they're doing and keep them on that same path, it's really important for their outcomes that way. And one of the other things too that you're going to see is potential for insurance reimbursement with this. You're not going to see insurance paying for it, but as a reschedule showing that there is legitimate medical benefit. I have seen some workers' comp cases that have already started reimbursing patients for their cannabis use. And I think you're going to be able to submit for some of that. I think clinicians are going to be able to bill for consulting patients on the, you know, cannabis and cannabis use as well. So it does open a lot of doors as far as that's concerned. But I really think just the idea that cannabis is safe and effective and has its medical benefits is really going to be the biggest impact on our clinicians. I think they're going to open up a little bit more and say, oh, well, the government says it's okay, so I think we can do that. In Connecticut, we have 41 conditions right now. We just got autism spectrum disorder passed a couple of weeks ago, where, you know, exactly, that's awesome. But to think that we've had a program since 2014 that they didn't have access to that medication, and doctors are trying to, well, they can fit in this category because they have this as well. And, you know, now they can finally start using the medications appropriately and not being misdiagnosed, which goes on to their medical files and everything too. And, you know, some other doctor wants to give them new medication for it or something as well. So I really think the access and the knowledge for clinicians are really what's going to be impacted the most. You're not going to see anything flowing into pharmacies. You're not going to need a prescription for anything anytime soon. It's not going to affect the state medical program, you know, medical cannabis programs or anything. It's going to be a while for that to happen. But that's a good thing because I think the education needs to be there for these clinicians and everything as well. So.
Okay. Thank you, Brian. I appreciate that. I think one of the, one of the challenges that we're seeing with patients is that, yes, it's, there have been so many barriers for patients to get into the medical cannabis programs in some states. And so where adult use has come on, you know, there are more patients that are able to have access. But on the other side of that, patients and adult use consumers aren't always looking for the same products. And so a lot of our patients are finding products that they were relying on vanish from the shelves. So, you know, specifically, a lot of adult use consumers are always looking for the next best thing, like what's new, what's hot. And for a patient, that's the last thing you want, right? On your way to work, you don't want to be trying something new, something exciting, or right before you pick up your kids. So I think that this sort of concept of wellness versus medicine is a little dangerous because it also means that those who can't afford those products will never have access as well. And so in this country, we have two healthcare systems, just like we have a lot of versions of two Americas. And I think that sort of leads us to our next speaker. We can talk about a class of Americans that on a couple days the year, we act like they're the most important, but who are definitely hit hard by these laws. And so I'll let Shanita walk us through the experience of veterans. And I also just want to say thank you so much for the work you do and the awareness you bring to these issues of veterans. So welcome.
Well, thank you for your support and thank you for having me here today. I'm very honored. As Steph said, I am a U.S. Army veteran. I served in Operation Iraqi Freedom and Operation Enduring Freedom. I am a disabled veteran. I am diagnosed with PTSD and I'm thriving and surviving by using cannabis. So I'm here today to discuss the critical issue of rescheduling cannabis and its potential impact on veterans' health and well-being. As we've all talked about, the DHHS and the FDA have recommended the rescheduling of cannabis from 1 to 3. For veterans, this isn't just a bureaucratic change, it's a potential lifeline for thousands of former service members struggling with PTSD, chronic pain, TBIs, and the devastating effects of opiate addiction. It can also foster a reinstatement of their constitutional right to bear arms, which for many service members, including myself, has been a barrier to entry into these state-run medical programs. The statistics paint a stark picture. Since 9/11, over 300,000 active duty members have committed suicide. After Vietnam, nearly 100,000 veterans took their own lives. That's almost double the 58,000 who died in combat. These numbers are a national tragedy and we must take action. 92% of veteran households support research into medical cannabis for mental health and physical conditions. 83% believe the federal government should legalize medical cannabis nationwide, and 82% want it as a federally legal treatment option. Despite this support, only 22% of veterans are actively using medical cannabis. Why? Because our current federal policy, veterans lack parity with their civilian counterparts. They're forced to seek care outside of the Veterans Health Administration to obtain a medical cannabis recommendation, which again creates an unnecessary barrier for those who have already sacrificed so much. State recreational programs or adult use programs, although Veterans Initiative 22 supports the passage of these laws as they ease access, it's also been a double-edged sword per se to our medical programs, as they have taken the priority in most states and put our patients on the back burner. Those who fought this fight and were on the front lines of legalizing medical cannabis. and at a time when our disabled veterans need to remain at the forefront of our thoughts when debating policy initiatives. Rescheduling cannabis to Schedule 3 could be a game changer. It has the potential to decrease reliance on more dangerous pain relief methods, particularly opioids, and studies show that cannabis has significantly fewer addictive properties and is less likely to result in dependency. Most importantly, it would facilitate research, potentially allowing the VA to assist with cannabis access and to integrate cannabis into the Veterans Health Administration, our nation's largest healthcare system. We know about 40% of people with PTSD also struggle with substance abuse, often using opioids to self-medicate. Cannabis offers a safer alternative to many current PTSD treatments. However, Schedule 1's status blocks critical research and prevents the VA from assisting veterans with access to cannabis therapy. And although the VA cannot withhold health services to veterans who use cannabis in legal states, the agency does not offer medical cannabis as a treatment or cover the cost for medical cannabis recommendations or reimburse the cost for cannabis products. My nonprofit was formed to bridge this gap for affordable access for our veteran community, as many former service members, especially those who are disabled, are already on a fixed income. They must pay out of pocket for their cannabis, and therefore they need a disposable income in order to afford this life-saving medication. Rescheduling could be the first step in closing this gap by allowing cannabis to go from recommendation to prescription for those who want a prescription. Therefore, the cost could be covered or reimbursed by the VA or private insurance. As we speak, opioids remain the leading cause of overdose deaths in the US, with 50,000 lives lost in 2019 alone. And tragically, a 2011 VA study found that veterans were twice as likely as the rest of the population to die from an opioid overdose. We have a moral obligation to explore safer alternatives for our veterans. The science is clear, but for veterans, this isn't just about medical efficacy. It's about easing the transition back to civilian life. It's about hope, offering hope and alternatives to those suffering from the wounds of battle. Schedule 3 will not affect active duty personnel, nor will it change the uniform code of military justice. It is one small step to hopefully lead to that one day. Rescheduling is not just a matter of policy, it's a matter of compassion and care for those who have served our nation. And that's again, thank you, Stephanie, for having me. Thank you, staff, for having me. I appreciate it very much.
No, thank you. And thank you so much for all that you do. I mean, I think that this this conversation is really what needs to be in the hearts and minds of everyone as they're looking at this decision. And so I'm going to take just a few minutes to kind of go over the what's next, and then we're going to take some questions. And I also have some follow-up questions for y'all as well. But I'll let the people that have joined ask first. Oh, okay. Okay, so the proposal that people are commenting on, people just talk about it sort of this open, like, cannabis goes from Schedule 1 to Schedule 3. And that's actually not quite true. That actually there's the definition of marijuana and marijuana extracts that actually get moved to a Schedule 3. But THC is actually scheduled separately from marijuana in Schedule 1. And they're actually recommending that that the THC stays in Schedule 1, except for some carve-outs that they put in the Schedule 3. And so this would be the synthetics and things that are not commercially available in the cannabis plant. And so, we've been talking about, that actually the DOJ is bringing both patients back into the conversation by accepted medical use, but they're also bringing the plant back into the conversation as they're talking about products. And so, I apologize, this thing jumps. So again, not only are they talking about moving marijuana, but they're still going to call it marijuana and not cannabis. But they did finally change the H to a J. But they specifically are talking about naturally derived THC delta 9. And again, they put an exemption for hemp, but this is really their way of keeping not only some of the products we've seen come from the hemp markets, but also spice and other substances that have been on the market that are similar to what we see in cannabis. And so they don't change the definition of marijuana or of hemp, which hemp is being actually debated right now in the Farm Bill. And there's a lot of sort of open questions about what this would mean as far as what would actually be rescheduled and what wouldn't be. The questions are really going to be like, where did the cannabinoids come from? If they're going to fall under the hemp rulings or under the marijuana laws. So there's a lot to be seen as far as what happens after rescheduling itself. DEA went out of their way to say that, basically to reiterate that the state programs would not become legal, that actually the DEA and Department of Justice would still have the ability to enforce cannabis laws. And also in the comments, we saw, oh, gosh, sorry, I don't know why this thing jumps like this. There's something to do with my, sorry. Hit this one. Okay. So sorry about that. I hope I'm not giving anyone a seizure jumping around. Sorry. What we saw in the comments was, basically every time the HHS had a position, that DEA was saying that they, basically they want to see more information, that they questioned HHS's finding. And so, this combined with questions that they asked of the legal counsel, it seems like the DEA is definitely teeing up for a administrative hearing, if not, a change in schedule, maybe Schedule 2, right? And so they definitely were asking, like, do we have to do what HHS says? And basically what the legal counsel came back and said that they had to adhere to HHS's findings for this process, this public comment process, but that through that process, as well as a potential hearing, the DEA could have another finding, that they could come back with a different conclusion. And one of the other focuses that has been a part of a roadblock for rescheduling in the United States has been the UN single treaties, the drug treaties. And we were able to actually reschedule cannabis at the UN level in December 2020. And so we're actually out of step with UN policies at this point. We wouldn't be jeopardizing those by moving forward with rescheduling. And so I think there's been a lot of questions about what this means, but the reality is it doesn't mean a lot for the state programs, for the people who participate in them, but it's a game changer for those of us who have been looking for recognition. Like you've heard from some of the patients on this call, hearing your government say that cannabis is medicine, it's like we've been aliens. For me, I've been like an alien in my country for 20 years. That it's, between the laughs or whatever, there's also real issues of traveling and seeing loved ones and visiting friends and family. And so knowing that we can at least have this conversation now about what, where cannabis fits into the framework, it's a game changer. But as people mentioned on this, it is not going to legally take away stigma, but it's going to create the opportunity maybe to have more conversations with your employer or with your doctors, maybe with your landlord, that maybe they would view your medical cannabis use a little differently. We're hoping that as we talk to Congress, it'll mean that these conversations will be a little more open, right? That will be backed by the health agencies when asking for access programs. But it doesn't address the issues that were brought up in the adult use programs, right? It doesn't address the sort of bifurcated system where patients are getting left out. It doesn't address the many issues that patients are looking at, like that were mentioned on the call. It doesn't automatically mean insurance coverage. It may open up some of those conversations, but it's not going to change employment, housing, healthcare protections, making sure that products are accurately labeled and free of contaminants. It's not going to basically grant patients the same rights that other medications that other patients with other medications have in this country. And as we were pointing out, there's a lot of people who are left out of these state programs. I think we mentioned a lot of those. Ellen mentioned issues going into hospitals for surgery. Dr. Vinegar mentioned patients in hospice who are not able to use medical cannabis, and really changes the way someone gets to die in this country. And of course, Jenna told us about the many effects on the lives of veterans. So there's still work to be done. And now everyone is sort of turning to Congress, because in this process, we're limited by what it means to have cannabis rescheduled to 3, but there not being a product that's going to be available for patients to get. And so, there is actually bipartisan support in Congress for medical cannabis. We've seen that in the passage of the Research Act in 2022. We've continued to pass protections for the medical cannabis program, although those are being dwindled a little bit right now. And what we're looking for at Americans for Safe Access is actually, I think a couple of the speakers mentioned it, is actually the establishment of an Office of Medical Cannabis and Cannabinoid Control in HHS, not FDA. And then we actually create a new schedule for cannabis, Schedule 6. And this is actually something that would take this out of the DEA, take it out of the sort of criminal penalty component. And this schedule would be overseen by the Office of Medical Cannabis. And so there are lots of resources on our website that goes into what this program would look like. I want to make sure we have more time for questions. But basically really looking at what would be the difference, what would a Schedule 6 look like? We've really, over the last 22 years, really looked at what could work for patients, and what the sort of healthcare sector is looking for to integrate cannabis into our healthcare systems. And right now we have sort of the compassionate use program at the state level, and there's a lot that we need to do to integrate that into the program so that we can address some of the issues like Dr. Vinegar was talking about, and Brian were talking about medical professionals not having the information they need, right? That, as Michelle spoke about, that there are a lot of medical professionals that don't even know that this is an option. But there are some gaps that we're going to have to fill, including standardizing the terminology, right? So that the researchers and doctors and patients are at least having the same conversation. And all of this can be accomplished under an Office of Medical Cannabis. And right now, besides the sort of challenges at the state level, and we look at the research bill that was passed, in what world wouldn't somebody want to research the 6 million people that are using medical cannabis right now, right? We're sitting on like the most exciting research project ever. And because of some of these obstacles, research is happening separate from medical professional education. It's happening separate from patients' needs and experiences, and it's happening separate from product development. And so by saying that we want to see medical cannabis move forward, we can invest in an Office of Medical Cannabis that can close these gaps for patients. And so what's next is definitely sort of a mystery to folks, but I know that patient advocates have a huge role to play in how Congress is hearing this, what the next moves are. There's a lot going on right now that puts these things up in the air. And so we are inviting folks to learn more about the legislation, so you can educate yourself as well as reach out to your members of Congress. We are having an event in DC in September to lobby Congress before they go home and start campaigning. So there's going to be a lot of things that are decided in the lame duck part of the congressional session. So we want to make sure people get their voices heard before Congress turns completely to the elections. And then, of course, during the election cycle, we invite people to join us in finding out where your candidates are. In the Compassionate Candidate campaign, we're creating tools for patients to engage with their with those who are applying for the job to represent you here in DC. And so if they're applying for the job, now is the time to ask them a little bit about their qualifications to serve you as a patient or as a patient stakeholder. And with that, yes,
We've got a couple questions.
I'm gonna get out of this real quick. Go ahead.
Okay, I'm gonna unmute Nicholas here and let him ask or directly. You can unmute Nicholas.
Hi there, can y'all hear me?
Yes.
Perfect. Thanks for taking my question. Nick over at Stat. I was curious, especially given what we were just hearing about talking about docs. I was hoping to get your all's thoughts on the fact that a number of physician groups, including the AMA and the American Psychological Association, have raised concerns with the rescheduling and are urging the Biden administration in their comments to reverse course. I'm curious for folks who's on the call's thoughts on that and whether it surprises you all, and if so, yes. If no, why not?
So I'll just say that I know that the American Psychiatric Association is one of the only associations that has not come out in support of medical cannabis. But that all of the medical associations and including everyone on this call, the patient advocates, want to see more research. I think the question is, for us, many of us that are living this, we know that our loved ones can't wait, or we can't wait, for access. And so, it isn't surprising that these organizations are calling for more research before cannabis is rescheduled. The American Medical Association has long been on the record of actually wanting to see cannabis rescheduled. Actually, they first took the position to reschedule back in 1999 when the Institute of Medicine put out their report that was completely ignored by Congress and the administration at the time to do so. I think that there's a difference between rescheduling and creating the opportunities that we're talking about, and sort of the misinformation that's been out there that rescheduling cannabis will mean that all of a sudden cannabis is in the water and everyone will have access. So I don't know if any of the other participants would like to answer, but I'd say that's those positions have been well known for a while.
Steph, can I just ask a quick follow-up question?
Yep.
Did you say that the AMA had supported rescheduling? I don't think I was aware of that. And in their comments here, they say that the AMA is concerned that rescheduling may send a mixed message to consumers that cannabis use is safe, which struck me a bit. I was a little bit surprised by their wording there. So I guess I just wanted to make sure I'm fully understanding what you're saying about AMA.
Yeah, so I think that is surprising that they would take that, but again, I think that is the impact from media coverage and not a fact of what's happening. And I think that one of the things with moving forward with rescheduling would be, and especially if we could create an Office of Medical Cannabis, is that right now Americans do not have a credible source to go to about medical cannabis, right? I think that for those of us who grew up during the drug war and saw that, like, this is your brain on drugs commercials, as we learn more about medical cannabis, that has definitely been broken down. But it is a concern when we look at all of the various cannabis products that are being sold, like at gas stations across the country, that people don't have somewhere to turn to decide what is safe. And so I think by moving forward with regulation, we're actually going to finally have a credible source. So it is surprising if they're saying not to reschedule. It would I'm wondering if they're saying between 2 and 3 would be my guess. But they have been on the record since 1999 saying that they'd like to see cannabis rescheduled, at least to Schedule 2, to facilitate research.
Got it. Thank you.
You're welcome.
Too, that it is even in the psychiatric community, I won't say that, I will say that that's the toughest. Like when I deal with that, like that is the toughest community. But I would also say there's power in patients and they're seeing a difference. Like I see they see the difference in my son. And so I do think that there's starting to be, I mean, there was a survey, I can't remember who did it, maybe 2 years ago, 25% of people who are autistic use it in some form, CBD, something, you know, so there's power in those numbers, right? Like there's power in that, and people are accessing it more than ever, and then doctors are being questioned about it and asked about it every day when patients come in, because they're reading more and more about it. So I do think there's power in numbers, and hopefully even that community starts to come around.
Yeah, and I'll also add that as far as all of the medical communities that have been sort of lobbied on this sort of anti-marijuana component, there was a disease disorder added called the cannabis use disorder in 2014, and one of the challenges, and we definitely see this at the VA, for instance, that when a doctor is taking in information about a patient's use of cannabis, in most cases, and definitely in the case of the VA, the only place where a doctor can put that information into an electronic database is under use of illicit substances. And so within the VA, if we've heard from many veterans that their doctors have said, don't tell me that you're using cannabis, because the only place that they can put that in in their records is going to trigger a response and a treatment category for cannabis use disorder. Because as cannabis is illegal, all use is abuse, which is also part of what we're seeing coming out in this rescheduling petition, which is a little crazy. And then secondly, I would just say within the psychiatric community, there's so much liability around treatments, around new treatments, and I think there's that doctors definitely err on the side of caution when introducing new treatments.
Yeah, I agree. I agree with that. Physicians want harm reduction above all else. And, I'm realistic. There are benefits and risks to every single medication or treatment that you take. I think doctors like myself for so many years, though, we're pretty much indoctrinated about the harms and the idea of a gateway drug, which has never really been shown. Probably the biggest gateway drug that we've all been exposed to is sugar, and we know what's happening in American society today with obesity and things like that. But in essence, it's, and I have colleagues that I work with on committees that are psychiatrists that understand there is some medical use, but they want to reduce the harm. And part of the problem is very early on, the National Institute on Drug Abuse used to fund research that was a bit biased towards harm. And then you were talking about young adolescents that were using illicit cannabis to get high, not under the care of a physician. And I saw in my state of Maryland, it's true that at the time it was legalized, the medical program, 10% of doctors had signed up to recommend. They're just not comfortable. They need more training about it. I think in 2017, the AAMC, the American Association of Medical Colleges, said only 11% taught about cannabis, but not even cannabis, the endocannabinoid system. I mean, I had been practicing for 20 years before I heard that word. So there's lacking in education for sure, number one. And, doctors want to be a little bit conservative, but I think that moving forward, they will come away. One of the worries, which too are these markets that are trying to appeal for adult use, that are trying to maximize the amount of THC in it. And then, so that's an issue. That's why if we had national standards of medications, with specific guidelines. We had the research to create treatment guidelines and standardized products. I think that would get away from it all. But, you know, certainly diversion and a young kid using high percentage of THC is not going to be good for them. But young people that have autism, seizure disorders, they make great developmental strides, you know? So I just think it's going to take some time and education, and then doctors will become a little more open-minded.
No, I think you're right. And I think that you know, it's so tricky for patients because patients are educating their doctors about cannabis, as Brian mentioned. But it's tricky for, you know, for a veteran to bring this up to their doctor, right? And so there's definitely, you know, fears of people getting kicked off of programs, off of insurance. And I think that, you know, the next sort of phase of the sort of fight for medical cannabis, let's say once we get past rescheduling, is the fact that cannabis is not attractive to big pharma. You know, that while there is money to be made, there's not obscene amounts of money to be made. And the reality is that cannabis really starts as a generic, right? That's what we're seeing in other countries that have national medical cannabis programs. And so we really need to you know, foster research, you know, utilize the NIH, and in countries where they have nationalized healthcare, they have an incentive to research cannabis, right? Because they want to bring those costs down. But also as far as doctor education goes, pharmacist education, a lot of that happens in this country through pharmaceutical companies. And so if you take them out of the equation, that leaves us sort of where we are right now, where you've got patients trying to bring information. And I think, again, this shows why we need an office dedicated to medical cannabis so that we can see not only the benefits that you're all expressing here on the call, but also some of the bigger impacts we're seeing on healthcare systems, right? The reduced prices, the reduced impact that a lot of countries have seen.
Excuse me, Steph.
Yes.
We're a little after 2, and I do have one more question that I
Sure.
would love to get in for you. Dr. Covens asks, will newly funded federal or nonprofit cannabis research be able to move forward upon the admin judge signature signing off?
So I think the challenge has really been and if you can get cannabis, if you can actually get the cannabis for your research. And I think that the you know, while this opens the door to maybe more companies applying for licenses to create cannabis for research, the current programs will still be outside of that. You know, there's very few research studies that are allowing, or IRBs are signing off on patients using cannabis from the state programs because of the lack of oversight. And so while we were able to break the NIDA monopoly on the cannabis that is grown under federal licenses, it's still a very small number. And so I think that you know, once you get the sign off from the IRB to do the study, the next question is where are you going to get that cannabis? And right now that is in the hands of about 6 companies. So, but thank you for the question. And I want to thank my panelists again. I hope that I can bring you guys back as things develop. And yeah, I hope that everyone who is attending really sees that there's a lot more about, you know, a lot more to medical cannabis than the sort of anti-drug component or what is going to happen to the cannabis businesses. And that, you know, behind this topic, there are over 6 million patients that have registered in some way with their state. And there's probably at least another 6 million who can't for whatever reason. And so we invite you all to join the call to Congress to find a solution so that we can advance cannabis policies. We can see medical cannabis integrated into our healthcare systems so that patients can worry about other things in their lives, like spending time with their loved ones, than trying to track down a second job for their medicine. So thank you all so much.